Hi, everyone, and welcome again to Anaesthesia Coffee Break. I'm Lahiru.
And I'm Stan.
And today we've got a few things to talk about. So we're going to talk about pulse oximetry. And I think that leads on pretty well because it's such a relevant thing for everyone. Even after the first part, you need to know about your pulse oximeter because otherwise, a lot of our management, one of the most common things that we'll ever do is to manage hypoxemia and hypertension. And, without the SATS probe, it's very, very difficult to actually identify any problems.
Well, yeah, we listened to Bob in the earlier episodes, and he was talking about the evolution of how monitoring has changed in anesthesia. And probably one of the big things that has come through is the pulse oximeter. Rather than having to look at the color of the patient, you actually have a number now to actually reassure you that that the patient's ventilation and perfusion is okay.
It's amazing what we take for granted, isn't it? The fact that, so many of our decisions are based on that number. And yeah, I guess what you're going to talk about is a lot of the, the errors in measurement or the problems with the pulse oximeter. So the fact that, these things is so, first of all, so vital to your management of your patient, but also the fact that we didn't always have a pulse oximeter. Yeah. Anyway.
Absolutely. And look, you're right. At the end of the day, it is just a number, and it's important to know how it works and what are the possible sources of errors, so that it gives you an idea in terms of where it may go wrong and other clues that you can sort of look for that the patient is being perfused, is being oxygenated. And those are the other important things. So yes, whilst I said it's moved on from the days when we, used to look at the color of the patient in terms of determining whether a patient has low saturations, it still doesn't take it away because errors do happen. And at the end of the day, we still need to look at our patients. And I'll just give you just a quick example before we go on to your performance tip. Just the other day, I was in recovery and the patient came out post-operatively, unfortunately came out cold, which is my fault. So we'll put that one on me. And one of the things that happens when you're cold is that you get vasoconstricted. And so they were trying to get this pulse oximeter reading in this patient who was quite elderly, and it was coming out in the 80s. And I was looking at her, and I looked at her, and she was fine during the anesthesia. And I was looking at her clinically, and I was going, I've seen patients with SATs of 80s, which is not a badge of honor, but I think we've both seen patients who are hypoxemic.
I've never seen that.
So you provide preventative CPR.
Let's just say 0 is not a very nice number to see.
Oh no, but you can see the grayish tinge of a patient who's or the gray bluish tinge of someone who's hypoxemic.
Definitely.
And I said, this patient looks pink, and I said it's most likely caused from her being cold, her being vasoconstricted, lack of pulsatile flow. Let's try another area. And so we tried somewhere on the ear, and yeah, true enough, her SATs were 99. But at that moment in time, if there wasn't that acknowledgement or that that understanding of how pulse oximeters works and where the errors can occur, you might be thinking that, oh no, you might actually need to intervene and start resuscitating this patient or ventilating this patient. All right, so apart from my little anecdote from earlier this week, we're going to start with a performance tip. So what's your performance tip?
Yeah, so the last month has been a bit of a weird journey for me. So the first thing that happened was I realized that I'm editing so many videos that I'm just running out of data space. So I started trying to figure out how to store data in the most, in the safest way possible. And then a week later, after I started sorting that out, my website stopped working. I started getting emails from students saying I can't download that content from anesthesiacollective.com. I went on to the website and it was just gone. Couldn't see anything. And so I tried to contact my web host and didn't get an email reply back. Another day, didn't get a reply back. And this is on the background. So Stan and I both started developing this website back in the day with another company, and they just disappeared. And then now this company has ceased to be communicative with me. And I had to go through a mate who recommended, and finally they replied. But essentially they were hacked and lost everything. So pretty disastrous result for a lot of time and effort in making this website. So my performance tip is really having data security backup. This is such an important thing in life in general, but also for your first part exam. Imagine all your notes these days. Most people probably have it on Dropbox or something, but you need something that's just a really reliable form of backup, because all of that data, all of that important information is going to be so important for you throughout the year of your study. And to lose it all to a crash or any kind of hacking event or anything like that is just a disaster for that will set you back a long way. And so something on this journey, something I learned while I'm looking up ways of solving this problem, was that in the data world, unless it's stored in 3 different positions, in 3 different places, it doesn't exist. So that means that not only do you have to have it stored maybe locally, but imagine that if you've got 2 backups locally, that's really good. But if you have some, if someone steals it, your house is robbed or there's a fire or a flood, then that's going to go. No matter how many backups you have at home, that's still not safe. You need to have it at 2 points. So having something in the cloud as well as in an external drive. And the other thing that I learned from this is that 100% of hard drives will fail in your lifetime. And that's a pretty bad statistic. And I think a lot of us have experienced that, where we might have, back in the day, something stored on a CD, the CD gets scratched, or the external hard drives, even though they're really solid state, or especially if they've got just the normal disk spinning, that can also easily break, or something can happen. You can drop it, and in time, all of these drives will fail. So I finally addressed this solution, and I finally got this ridiculous NAS drive that backs up itself overnight, and it also goes to cloud storage. And I've finally got a password generator so that everything is incredibly secure, I hope. So that's my performance tip. Make sure you back up your data, and make sure your passwords are secure, because it's an absolute nightmare trying to fix it. And luckily, everything I've done is recoverable. It's just knowledge in my brain I can reproduce, and I've managed to find a really old website version of it. But you just don't want this to happen, especially in something far more important than just a little hobby. If your first part is your career, and you don't want this to happen.
That's really important. And the idea of backing up is really a philosophy of how you should approach this exam, in terms of making sure that you have those other aspects of your lives are planned for, and in terms of things that are going to go wrong, try to minimize and mitigate those circumstances. Because the last thing you need during an exam is, in studying for this exam, is having this unnecessary stress of trying to figure out, where am I going to recover the data from? Yeah. So it's really, really good advice, I think, for everyone out there, to make sure that whatever they have sort of stored during this time when they're sort of preparing for their study, make sure that you actually have a backup.
Yeah. And probably the easiest way, I've obviously got a lot of data, so I've used quite a fancy solution with terabytes and terabytes of space. But I think the easiest thing, if you knew nothing about data, literally just get a Dropbox account, sync it to your laptop, so you've got it as a Dropbox with all your folders, and that automatically syncs. It's available on the cloud as well as your laptop, but that's only 2 points. And potentially just buying a solid external hard drive, 2 terabytes or whatever it is. You can get some really good solid state ones for a reasonable price now, as well as the cheaper HDDs. And then just every now and again, just back up your Dropbox with all your files onto that. So that's 3 points. That's on your laptop, in the cloud, and on external drive. So it's very, very unlikely that you'd lose all 3. And that's probably the simplest and cheapest solution to having 3 points of backup for all your very important first part files, as well as your other documents.
Did you manage to get all your data back, or what happened with that case?
Yes. So I had to go to the original website developer, who just disappeared. But luckily, they're actually there, but they're doing something completely different now.
Oh, right. What are they doing now? They're not called Bevel anymore?
Are they called Bevel?
Are they called Bevel?
But yeah, I don't trust them.
So it's not a plug. So it's a plug. It's a plug out as opposed to a plug in.
Yeah, it's funny when they're when they're helping us, they're obviously, we're website developers, but literally they've just transitioned to something completely different, left all of us behind.
Right.
Left the website development space, or even, helping us with things like updating the security certificates. And they've just gone to a more social media style development.
Right.
But yeah, you just can't trust other people to take care of your stuff for you. They didn't have a backup but I managed to point the website at an old IP address, and it just appeared as an older version.
Right.
So really lucky that was still present. I don't really understand it. A bit annoyed by this whole process, but it's a very it was a cheap mistake overall from the mistakes that could have happened, and now I'm sorting it out.
Yeah, managed it. Yeah, and you're moving on. So let's
move on.
Moving forward. Yeah,
things happen.
All right. So
Okay.
let's get into this question. And this was a question, I think, from 2016. And I think it's been asked previously in the past, which is explain the reasons why a pulse oximeter may give incorrect readings.
Mm-hmm.
So for this question here, the basic principles of a pulse oximetry is that it measures hemoglobin O2 saturations using the Beer-Lambert law. So in its simplicity, the Beer law states that the amount of absorbance of a transmitted light is dependent on the concentration. And the Lambert law states that the amount of absorption of a transmitted light is dependent on the length it travels. So that's where the Beer-Lambert law comes from. And there's a formula that you'll see in textbooks, which combines those two sort of concepts together, as well as what's called the extinction coefficient of the solute. Now, what is, I think, important to make the distinction is that pulse oximetry measures functional saturation, because the other one that you'll also see is called fractional saturations. And this is where there is a bit of confusion. So fractional saturations is what co-oximetry measures using a sample from an arterial blood gas. And co-oximetry is able to measure all the different hemoglobin species that may possibly exist in blood, so sulfur, HB as well, okay? Whereas a pulse oximetry, what it does is it measures the difference between oxygenated hemoglobin over total hemoglobin, which is both oxy and deoxyhemoglobin. And the way it does that, it uses two wavelengths. So very easily, it uses the red wavelength at 660 and the infrared wavelength at 940 to measure oxy and deoxyhemoglobin. Now, you're going to ask, why do they choose 660 and 940? Well, if you actually look at the actual diagram itself, so at 660, what you see is that deoxyhemoglobin has more absorption of red light than oxyhemoglobin, which makes sense because if you think about it, deoxyhemoglobin absorbs red and shows itself as blue, whereas oxyhemoglobin is able to reflect red light, and that's why you see that pinkish color. Now, on the flip side, on the infrared spectrum, you actually have it the other way around. So oxyhemoglobin is actually able to absorb a lot more infrared than deoxyhemoglobin. And when you see that, it's because of the differences between the two, because the way that it's calculated in a pulse oximeter, it uses a ratio. So it's looking at the ratio of absorbance between the oxy and deoxyhemoglobin at the red spectrum versus the oxy and deoxy at the infrared spectrum.
So the ratio, I mean, that's calculated as like the pulsatile blood absorption.
Correct.
Yep.
Yeah, correct. So what you'll see is this R ratio, which is calculated as you see it in different texts where you see this formula where you see the AC and DC. So the AC, which is alternating current, is pulsatile flow, and the DC is direct current, which is non-pulsatile flow. So what the inference is that pulsatile flow contains oxygenated hemoglobin, whereas the non-pulsatile flow contains deoxy or reduced hemoglobin. Okay, and then by knowing what the pulsatile and non-pulsatile flows are, they're able to make inferences in terms of what the oxy and deoxyhemoglobin is, look at the ratios between the two at red, and then also look at the ratios of them at infrared, and then they look at so it's actually the ratios. There's two ratios, and they compare them. So there's the ratio of the ratio of the ratio. Okay.
Exactly. And specifically, so AC absorbance at 660 over DC absorbance at 660 is then divided by, so is then ratioed AC absorbance at 940 over DC absorbance at 940. So you're just doing ratios of ratios.
Correct. So there's actually, the ratio, another ratio, and you're comparing those ratios together. And that actually gives you an R value. So you'll see some R values, I think in textbooks, where an R of 1 is representative of a saturation of 85%. Okay. And then the lower your R value is, the higher saturations are. And the higher your R value is, the lower your saturations are. Now, where do incorrect readings come from? So incorrect readings, the way that, if you actually read the examiner's report, the way that they want you to classify it is that it can come from limitations of the central processor. It can come from the errors at the level of the probe. And then thirdly, from patient factors. So with regard to those three ways that they've categorized it, there's many different ways that you can think about it, because in terms of, the limitations of the central processor, what you can talk about, which can also include patient factors as well, but we can talk about the different hemoglobin species that are out there and how different hemoglobin species can produce erroneous pulse oximeter readings. So, for example, carboxyhemoglobin, which we're talking about previously in your perfusion diffusion talk. So carboxyhemoglobin actually shares very similar absorptions to oxyhemoglobin at 660. So if you look at the graph of the absorbance, what you'll see is that at 660, carboxy and oxyhemoglobin are almost identical. And that's the reason why that when you look at the pulse oximeter, it tends to trend towards the high 90s for when you've got carboxyhemoglobin poisoning or carbon monoxide poisoning. Now, conversely, when you look at methemoglobin, so with methemoglobin, it actually shares very similar absorptions again with deoxyhemoglobin at 660. And that is why in the presence of methemoglobin, you tend to get lower saturations, and your R value, which is that ratio, tends to approach 1. So you tend to get saturations of 85%. So look, the clue is when you're thinking about how to draw this diagram, because you will be asked to draw the diagram in the exam, either in the Viva or in the written, the way to think about it is you need to have the two numbers in your head, 660, 940. At 660, know that oxyhemoglobin is red. Okay, so if it's red, it's going to reflect red, and deoxyhemoglobin is often blue. So it's going to absorb the red light. In other words, your absorbance of deoxy is going to be higher than oxyhemoglobin. Now at 940, it's the reverse, because remember, they're looking at the difference between the two sort of ratios. So at infrared, oxyhemoglobin is going to have higher absorbance, and deoxyhemoglobin is going to have lower absorbance. All right. And then when you get asked to draw the carboxy and methemoglobin, the starting point is know that carboxyhemoglobin shares the same absorbance as oxyhemoglobin. So it's going to cross over 660, whereas methemoglobin shares the same absorbance as deoxyhemoglobin. So those two are going to cross together.
So
all right.
Maybe we'll probably put a link to the appropriate diagram in the story notes.
Yeah, and the diagrams are readily available in fact in all textbooks. And I think it's actually quite good if you can sort of think about conceptually in your head the reasons why, as I've explained, where they sit. It'll actually help you draw the diagrams, because I know from asking trainees this question, they get very confused about how to draw this diagram. But if you actually understand the concepts about the different absorbance, I think it'll actually give you a good starting point in terms of where each one goes.
And when I think about this clinically, when this is so relevant, depending on which hospital you work at and the patient population that comes in, say you have a trauma patient with inhalational injuries or burns injuries, you may be falsely reassured by the fact that their sats are fine, but you may have missed
with the carboxy. Yeah,
you may have missed the point that they've actually got a lot of carbon monoxide from smoke inhalation injury, or maybe it was a suicide attempt or something like that. and you just have to treat with oxygen, regardless of what that oxygen level is. And likewise, you might have someone who's, methemoglobinemia. Say you've got someone, I think is it S&P that creates increased hemoglobin.
That's right.
You may get a trend down to 85%, and you really have to be aware of that. These are the situations that it occurs. But yeah, so fetal hemoglobin and HbS doesn't really affect the pulse.
No, so not as not clinically relevant, and because of that. They do mention it in textbooks, but because they don't have that much of an effect, I tend to leave them out in this answer, because this answer is really talking about why a pulse oximeter may sort of give incorrect readings. Now, the other thing with the pulse oximeter is that know that it's calibrated for patients between 70 to 100%. Mm-hmm. Right. So in other words, your accuracy is really limited within that range. Mm-hmm. And the reasons for that should be obvious in terms of when you think about the relevance of the HbO2 dissociation curve. So when you're reaching that steep part of the curve, any sort of small changes in your partial pressure of oxygen will produce very large changes in your saturations. And then the other thing to also note is that in patients with pathological conditions who often will have lower saturations, they've got variable HbO2 dissociation curves, because we know that it shifts left or right depending on your pH, your temperature, your CO2, and the presence of 2,3-DPG. Mm. So that's why the accuracy of the pulse oximeter is really limited to saturations above 70%. Once you head below then it gets very, very inaccurate. And I think you've seen that yourself, haven't you? When sats drop.
Yeah, it just drops really rapidly.
It dropped very rapidly. Yeah, and it's quite and I say heartbreaking, because and I'm sure with yourself, when you've done so many anesthetics, your heart is in tune with that high pitched sound of 99%. Yeah.
Yeah. Anything that goes beep 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 beep.
Oh, like even then, it's inversely. It's the lower the frequency, the higher my heart rate.
Yep.
And it's just this Pavlovian response,
isn't it? Yep. Yeah, and it's funny that you get attuned to these things, not just the pitch of that saturation trace, but also the beat of it. So you get a small rise or a slowing down of it, and you're like, "Whoa, what's just happened?"
Yeah.
I recently did a squint repair, and I just pre-treated with atropine. Something I really didn't want to see a drop, and
drop in the heart rate. Yeah,
that's right. Traction on that muscle can create some severe bradycardias, even asystole. And even I gave 300 just 300 of atropine. Heart rate was pretty much 85 for most of the case, and traction on the muscle made it go down to 75 pretty much instantly. So
and there you go. And so with when you also think about the other errors of pulse oximetry and where it can occur, so know that it's got LEDs at the probe level. So any sort of damage to the LEDs can affect the level, can affect sort of the O2 saturation. And you'll see it sometimes after a new case has started, where the pulse oximeter was working in the previous case, and something has happened in between the case, either incorrect cleaning or someone's damaged the LED. When you try to pop it onto the finger, it just doesn't work anymore.
Yep.
Yeah. I've seen that sort of multiple times.
Yeah, that's right. It's quite painful and again, you rely on this so much that any kind of breakage. I remember there was a period of time where the SATS probes seemed to just not be working, and have to go and get a different, different line, different SATS probe quite frequently.
Yeah.
And it can be very frustrating.
That's right. Now, the other thing that is very, very common in anesthesia is the interference that you get. So the way that I've sort of summarized it is that there's motion artifact, so patients moving or shaking, and there's optical interference. There's also electrical and infrared interference as well. Mm-hmm. Now, there's ways that you can mitigate those types of interferences. So one is that people often wrap up the SATS probe with a covering to sort of minimize the optical or infrared interference. Mm-hmm. And things like electrical interference, just move it away from the electrical interference. And the most common one is going to be diathermy. Mm-hmm. So you see that diathermy close to the pulse oximeter, you'll see high frequency waves, and it'll disrupt the saturations reading.
I've got to see that. I've got to say that that's been very infrequent for me. I haven't seen too much interference. Maybe the new models are a lot better at.
Well, I think the filters are quite good.
Yeah.
I do see it sometimes, especially if you decide to use, the ear or the ear or the ear probe, and they're sort of operating sort of close to where the ear probes are. What you'll see is sort of the high frequency, and then you actually see the sats. It won't give a reading at all. In other words, it'll know that there's a lot of sort of interference there.
Mm-hmm. That's right.
Now,
and so what do you do about the nail polish issue? Often advice to patients: remove nail polish before coming to a procedure. But sometimes you get these massive fake nails. What do you do about that?
So, okay, ideally you should get, and these are listed under patient factors that are listed under patient factors in terms of either dark nail polish or coverings, and they're often the ideal thing is that they haven't have them removed prior to coming in, or at least have a finger off. But understanding also that these are quite expensive. I think they're quite expensive. I can't confirm that, but I know that people obviously do spend a bit of money on them. So look, I'm a bit more practical in my approach, and if they're not too long, what I'll do is, instead of popping the probe on top of the fingernail, I'll pop it on the side of the finger, and it works just as well.
Yeah, and you're literally just rotating it 90 degrees, so now it's on the pulp instead of over the nail bed. It's on the pulp. That's
right. It's on the transverse instead of the nail bed. Yeah,
I've also just moved it up, so I'll just put it across the the proximal phalanx of the thumb.
Yeah, and we'll talk about that and what the possible errors of doing that are.
Excellent.
Yeah. So yes, that is an option, as long as the finger's not too large. All right, because if the finger is too large, you're going to get what's called an optical shunt, or you see this called penumbra effect, where it's not completely over the finger, and they produce you'll see in textbooks. I think one textbook calls it the penumbra effect, and then another textbook will call it the optical shunt. All right, and now in this day and age where we have ear probes, I just use the ear probe. So look, I'm not too fussed too much about nail coverings and nail polish. I mean, how about yourself? Do you routinely ask patients to remove nail coverings and nail polish?
No, not at all. I mean, that's never been our place. We're not really in that presence of talking to a patient before and telling them, by the way, remove your nail polish. Plus, there's an easy solution: just put it transversely across the finger rather than across the nail bed.
Yeah, exactly. Now, the other thing that you often see quite commonly, especially in breast surgery, is when they use dyes. So
that's interesting.
Yeah, methylene blue, and you'll see it in recovery as well. I always walk past a patient after they come out of breast surgery and where they've been exposed to methylene blue, and I go, "Oh, that patient's looking pretty hypoxemic," but it's not because they're looking bluish, grayish. It's because of the dye, and that in itself can actually produce incorrect saturation readings.
It's quite remarkable, isn't it? And every now and again, say a gynae surgeon wants to check whether the ureters are intact, and so they ask you to give methylene blue, and so you give that, and what they're looking for is to see the blue dye out of the ureters, just as they're checking with the cystoscopy after the operation. And it's really interesting because you go, hey, you'll notice something happening now, and you might tell your registrar or your nurse, and the sats just suddenly drop very acutely because it's intravenous.
Yes.
And it makes everyone kind of stand up a bit if they haven't seen it before.
Yeah, well, you're wondering, because the thing is they're associated with a rate of anaphylaxis.
Yeah, that's right.
So you're thinking, oh my, has this patient developed sudden drop in cardiac output and loss of perfusion, and that's why they've dropped their saturations.
Right. And it's interesting because for so long we in the hospital they ask for methylene blue, but then one of my surgeons just starts giving them Berocca or vitamin B complex in the morning of the operation, and so once because the urine gets very, very quickly very bright yellow.
Yes,
that I find is a far safer alternative to giving a potentially anaphylactic drug. So just giving Berocca or vitamin B complex in the morning with a small sip of water then allows them to check the ureters patency through cystoscopy, because it's very clear when you're getting passage of Berocca Urine.
through the urine. Yeah,
Yeah.
interesting. Now, the other thing that's interesting, and maybe you can sort of relate your experiences with this as well, is that, after the use of dye, it's transient. Like I never see it persist
No, never.
throughout the case, right? So even though I see patients have that bluish or greenish color tinge on their face, it never seems to be a permanent effect with their pulse oximeter. So yeah, I'll see it transiently drop, but then after a period of time, it comes back up again. But when you see patients, they're looking, they're looking pretty blue, or they're looking pretty green. I mean, is that sort of similar to what you've experienced as well?
I mean, I've not seen the patients looking at, and look, I've got to say, I haven't seen the patients, except for intravenous methylene blue given, which is the transient issue. I haven't seen the patient looking blue or any odd color afterwards. No.
Yeah. And so, look, the last sort of patient factor is that the pulse oximeter does rely on pulsatile flow. And as I sort of mentioned before, and we were sort of discussing before, pulsatile flow is representative of oxyhemoglobin. So anything that disrupts the rhythm of the pulsatile flow is going to cause erroneous readings. So these can include irregular rhythms or dysrhythmias, arteriovenous pulsations, sort of maybe an AV fistula, can lead to pressure waveforms that confuse it. And also the way that your intra-aortic balloon pump is being programmed. So there are multiple ways to program an intra-aortic balloon pump, far beyond my level of understanding. And, maybe one day we'll have someone who's an ICU consultant who's very familiar with intra-aortic balloon pumps come in and have a chat to us about it. But from my sort of basic knowledge of that, there are multiple waveforms that you can sort of create with these balloon pumps, depending on the patient's pathology. And because of that, these can confuse the pulse oximeter algorithm.
Ah, I see.
Yeah. Now, did you have anything else that you had that wasn't that I might have missed out?
So I think you covered it really well. So, I mean, in summary, I think you've gone through a lot of the patient factors that could cause the problem, talking about the factor at the level of the probe itself, and then factors at the central processor, and just going through this systematically. I really like that. So I think that pretty much covers it. Well, what I was going to say is I remember just having a case where there's a patient with potentially difficult airways, like a Crest syndrome patient, small mouth opening, but also because of the syndrome or this, the connective tissue type problem that they had, we could not get a SATS trace anywhere. And that was interesting because I've got a potentially difficult airway and a patient who can't get a SATS trace on. But my consultant at the time was just absolutely fine. They said, yeah, don't worry, it'll sort itself out. Gave the propofol, and then just the propofol vasodilation sorted out the SATS issue.
There you go. Yeah.
Unfortunately, it wasn't a difficult airway. Everything was good. But I thought, that was interesting to know. That was my N=1 for very small vessels or very little pulsation detected by the probe. But I'm happy that anesthesia really promotes good blood flow to your peripheries.
And would you do that again? Like, would you be comfortable doing a case without a pulse oximeter?
I mean, because it came on straight away, it was fine. But yeah, I mean, what would I do if this was, say you actually have no pulse oximeters in this institution, maybe you're in third world.
Well, let's say for some reason, and I've had scenarios where it's been difficult to get oxygen saturations. Yeah, like how would you manage? And I know this is probably like a part 2 question, but
it's interesting.
Just out of interest. Yeah, what would you do?
If it's an elective procedure, then chances are I'd have to try and find a solution. If it's a patient issue, then potentially there's no solution that I can find. So I need to crack on and make the best of what I have. So in the situation where I need to crack on, either it's a developing world issue or it's a patient issue that can't be solved, and depending on the urgency of the case, I think I'd go ahead understanding the limitations and potentially putting in an outline to get some regular saturations via the PO2 measurements through the co-oximetry of the gas. I'm just trying to think, is there any other ways besides having a really good idea of, here's the thing, right? So if I am regularly making sure ventilation is fine, that I'm giving it appropriate FiO2 and there's no problems with the compliance and the lungs sound good, I think I could be very vigilant. Regular assessment of the lungs, regular assessment of my various parameters of ventilation, my FiO2, and the occasional blood gas, I think I'd be in a safe environment.
Yeah.
And this comfort level would be increased if it's peripheral surgery with a well patient. And I'll be very uncomfortable if this was thoracic surgery with a patient with lung disease and everywhere else on that spectrum.
Absolutely. Yeah. I'm the same as you. Like, I'd probably be a bit more conservative in my FiO2 and probably have it higher than usual. But all sort of those other things you sort of talk about in terms of just looking at the other parameters, the heart rate, the blood pressure, and I guess just going back to old school, just looking at the color of the skin.
Yeah. Actually, I did have an experience when I was working in the Northern Territory where I had a child who desaturated, had probably a mild laryngospasm, desaturated at 40%. And I'd never seen a dark-skinned person desaturate, right? And what that actually looked like. So, we talk about the patient looking a bit gray or blue if they've got pale skin, and that's probably common to most people in the Australian context. But to see the difference in color of a person who's dark-skinned, it was very noticeable. And so it's probably something that for the audience to realize that everyone looks far more gray or just doesn't look quite right, regardless of their skin color.
Yes,
and that was eye-opening.
Yeah, and look, and just as to add on to that, people do ask whether skin color does affect pulse oximetry readings, and there has been some studies shown that probably at lower saturations it possibly might, but it's been very inconclusive. But in general, we say that no, it doesn't. That skin color has minimal effect on the accuracy of pulse oximetry readings.
I think we probably covered most of the stuff there. So again, thanks very much, Dan. That was a really good framework for the answer, and I love the detail of this. And that's the kind of detail that hopefully you'll be able to reproduce in the exam, especially with the understanding of these concepts, which we hope we got through to you. Please share and recommend to anyone who might be interested in this, especially if they're sitting their first part exam. And we'll see you next time. Thanks a lot.